Welcome. This is the New England Journal of Medicine. I'm Dr. Michael Beerer. This week, September 19th, 2024, we talk about long-term oxygen therapy in severe hypoxemia, reducing opioid overdose deaths, blocking CSF1R in chronic GVHD, and pomalidomide in hereditary hemorrhagic telangiectasia. A review article on central nervous system vasculitis, a case report of a man with confusion and kidney failure, a medicine and society on House staff unionization revisited, and perspectives on ethical challenges in pragmatic and cluster RCTs, on the sense and sensibility of sensitivity analyses, and on there being no one in charge. Long-term oxygen therapy for 24 or 15 hours per day in severe hypoxemia by Magnus Ekström from Lund University, Sweden, and co-authors. Long-term oxygen supplementation for at least 15 hours per day prolongs survival among patients with severe hypoxemia. On the basis of a non-randomized comparison, long-term oxygen therapy has been recommended to be used for 24 hours per day, which is a more burdensome regimen. This trial involved 241 patients who were starting oxygen therapy for chronic severe hypoxemia at rest. The patients were randomly assigned to receive long-term oxygen therapy for 24 or 15 hours per day. No patient was lost to follow-up. At 12 months, the risk of hospitalization or death within 1 year in the 24-hour group was not lower than that in the 15-hour group. Mean rate 124.7 and 124.5 events per 100 person years, respectively. The groups did not differ substantially in the incidence of hospitalization for any cause, death from any cause, or adverse events. Among patients with severe hypoxemia, long-term oxygen therapy used for 24 hours per day did not result in a lower risk of hospitalization or death within 1 year than therapy for 15 hours per day. Darren Teichman, deputy editor for the journal, and Jeffrey Drazen, NEJM group editor, write in an editorial that although a larger trial may show a difference in mortality between 15 hours and 24 hours per day of oxygen therapy, the current results should reassure patients and clinicians that such a difference would probably be quite small. Added to the lack of an apparent difference in patient-reported functional outcomes, the results provide peace of mind that we can lessen the burden of long-term oxygen therapy, at least somewhat. However, even with 15 hours per day of therapy, many burdens remain for patients receiving long-term oxygen supplementation. Among these patients, nearly half cite mobility limitations due to their oxygen equipment as the most important challenge to improving their quality of life, with nearly a third of patients needing help from another person to carry it. In the United States, current payment policies of the Centers for Medicare and Medicaid Services prevent many patients from obtaining more portable and durable systems that might alleviate these impediments. Bipartisan legislation before the U.S. Congress aims to address these barriers so that the oxygen delivery system provided to a patient is determined according to medical necessity and not by financial considerations. Long-term oxygen therapy would ideally provide a ticket to freedom for patients with severe hypoxemia at rest, rather than a ball and chain that is added to their physical and emotional burdens caused by underlying disease. These new data suggest that the ability to reduce the daily hours of oxygen supplementation without fear of long-term harm makes it possible for a patient to think about attending a concert or family gathering without the oxygen apparatus. Community-based cluster randomized trial to reduce opioid overdose deaths. By the Healing, Helping to End Addiction Long-Term Initiative Communities Study Consortium. Rates of opioid-related overdose deaths have been a rising scourge in the United States, with an increase in the annual number of deaths from 8,050 in 1999 to 82,136 in 2022. This increase was initially attributed to excessive opioid prescribing and more recently to the expansion of fentanyl in the illicit drug supply. Evidence-based practices for reducing opioid-related overdose deaths include overdose education and naloxone distribution, the use of medications for the treatment of opioid use disorder, and prescription opioid safety. This 12-month trial evaluated the effectiveness of a community-engaged intervention to reduce opioid-related overdose deaths through enhanced uptake of these practices. 67 communities in Kentucky, Massachusetts, New York, and Ohio were randomly assigned to receive the intervention or a waitlist control, stratified according to state. Intervention communities implemented 615 evidence-based practice strategies from the 806 strategies selected by communities, 254 involving overdose education and naloxone distribution, 256 involving the use of medications for opioid use disorder, and 105 involving prescription opioid safety. During the comparison period from July 2021 through June 2022, the population averaged rates of opioid-related overdose deaths were similar in the intervention group and the control group, 47.2 deaths per 100,000 population versus 51.7 per 100,000 population. The effect of the intervention on the rate of opioid-related overdose deaths did not differ appreciably according to state, urban or rural category, age, sex, or race or ethnic group. In an editorial, Daniel Ciccarone from the University of California, San Francisco, writes that the Healing Communities study represented an outstanding collaborative effort by funders, scientists, community partners, and their staff. However, the study intervention was unsuccessful in bringing down the overdose death rate. The complex interventional components were evidence-based and community vetted, and the study design was excellent. So why did this effort not have a statistical effect despite its strong components and seemingly ample funding, more than $4 million? The authors suggest, rightly, that the COVID-19 pandemic was a major contributor to the disruptions and challenges in the healthcare workforce. The authors raise two additional issues that deserve emphasis. First, the trial was underpowered with unrealistic a priori expectation of a successful trial showing a 40% reduction in overdose deaths in the intervention group. Second, an increasingly toxic and unpredictable drug supply has led to a rising and for a time seemingly unstoppable tide of overdose deaths. Finally, and most dishearteningly, we are not adequately addressing the underlying structural causes of the opioid crisis. Evolving licit and illicit drug supplies are part of this structure, but so too are social determinants of health. Amid this gloomy forecast, there is a silver lining. As of late 2023, most eastern U.S. states have had a substantial decline in overdose numbers as compared with the previous year. Of the 4 states that were included in the Healing Communities study, all have seen relative reductions in overdose deaths by 11.4% in Massachusetts, 8% in Kentucky, 7.9% in Ohio, and 3.5% in New York. Have we scaled up our responses to the level necessary to bend down the curve? Many would argue that the current investments are still not enough. Axatilimab in recurrent or refractory chronic graft-versus-host disease by Daniel Wolf, from the University Hospital, Regensburg, Germany, and co-authors. Colony-stimulating factor I receptor, CSF1R, dependent monocytes and macrophages are key mediators of chronic graft-versus-host disease, GVHD, a major long-term complication of allogeneic hematopoietic stem cell transplantation, HSCT. The CSF1R blocking antibody, axatilimab, has shown promising clinical activity in chronic GVHD. This phase 2 trial evaluated axatilimab at 3 different doses in patients with recurrent or refractory chronic GVHD. 241 patients were randomly assigned to receive axatilimab administered intravenously at a dose of 0.3 milligrams per kilogram of body weight every 2 weeks, 0.3 milligram dose group, at a dose of 1 milligram per kilogram every 2 weeks, 1 milligram dose group, or at a dose of 3 milligrams per kilogram every 4 weeks, 3 milligram dose group. The primary endpoint of an overall response, complete or partial response, in the first 6 cycles was met in all the groups. An overall response was observed in 74% of the patients in the 0.3 milligram dose group, 67% of the patients in the 1 milligram dose group, and 50% of the patients in the 3 milligram dose group. A reduction of more than 5 points on the modified Lee symptom scale was reported in 60%, 69%, and 41% of the patients in the 3 dose groups, respectively. The most common adverse events were dose-dependent transient laboratory abnormalities related to CSF1R blockade. Adverse events leading to discontinuation of axatilimab occurred in 6% of the patients in the 0.3 milligram dose group, 22% in the 1 milligram dose group, and 18% in the 3 milligram dose group. Targeting CSF1R-dependent monocytes and macrophages with axatilimab resulted in a high incidence of response among patients with recurrent or refractory chronic GVHD. In a Science Behind the Study editorial, Mohamed Moti from the Sorbonne, Paris, writes that axatilimab suppresses the proliferation and activity of macrophages by blocking the binding of ligand to CSF1R. Macrophage infiltration of affected tissues is a biomarker for the occurrence and development of GVHD, which is consistent with the established role of macrophages in the pathogenesis of GVHD. Macrophages are cells that present self-antigens and alloantigens to T lymphocytes, thereby initiating and perpetuating immune responses. After conditioning for HSCT, which typically involves radiation therapy, chemotherapy, or both, the presentation of immunogenic self-peptides, antigens, by macrophages is enhanced, owing to the release of molecules from dying cells that are not normally present in the extracellular milieu. After HSCT, the presentation by the host's macrophages and other antigen-presenting cells of antigens derived from the host may activate an immune response from donor immune cells against the host's tissues. Such presentation of host antigens to donor alloreactive T lymphocytes may initiate and perpetuate immune responses that lead to acute and chronic GVHD. Targeting macrophages or their downstream products, therefore, represents a therapeutic strategy to prevent or treat chronic GVHD. Axatilimab is a welcome addition to the therapeutic armamentarium, given its mechanism of action and capacity to rapidly induce a clinical response, including in all involved organs, especially in prototypical fibrotic manifestations in the lung, esophagus, joints, fascia, and skin. These responses appear to be durable and not influenced by the extent of organ involvement or by previous exposure to ibrutinib, ruxolitinib, or belumosudil. Clinical trials to evaluate the efficacy of axatilimab in an earlier stage of chronic GVHD or in the prevention of chronic GVHD are warranted. Pomalidomide for epistaxis in hereditary hemorrhagic telangiectasia by Hani El Samkari from the Massachusetts General Hospital, Boston, and co-authors. Hereditary hemorrhagic telangiectasia, HHT, is characterized by extensive telangiectasias and arteriovenous malformations. The primary clinical manifestation is epistaxis that results in iron deficiency anemia and reduced health-related quality of life. This trial evaluated the safety and efficacy of pomalidomide, which, among other actions, directly inhibits angiogenesis for the treatment of HHT. 144 patients were randomly assigned in a 2-to-1 ratio to receive pomalidomide or matching placebo for 24 weeks. The trial was closed to enrollment early after a planned interim analysis met a pre-specified threshold for efficacy. The primary outcome was the change from baseline through week 24 in the epistaxis severity score, a validated bleeding score in HHT, range 0 to 10, with higher scores indicating worse bleeding. The baseline mean epistaxis severity score was 5, a finding consistent with moderate to severe epistaxis. At 24 weeks, the mean difference between the pomalidomide group and the placebo group in the change from baseline in the epistaxis severity score was minus 0.94 points. The mean difference in the changes in the HHT-specific quality of life score between the groups was minus 1.4 points. Adverse events that were more common in the pomalidomide group than in the placebo group included neutropenia, constipation, and rash. Among patients with HHT, pomalidomide treatment resulted in a significant, clinically relevant reduction in epistaxis severity. No unexpected safety signals were identified. Primary nervous system vasculitis. A review article by Carlo Salvarani from the Mayo Clinic, Rochester, Minnesota, and co-authors. Primary central nervous system, CNS, vasculitis is a rare, frequently misdiagnosed condition that affects the brain and spinal cord and is characterized by a variety of neurologic symptoms at presentation. The most common manifestation at the initial presentation has been a sudden onset of focal neurologic deficits, which is suggestive of an ischemic event such as a stroke or transient ischemic attack that includes aphasia, ataxia, and visual field defects. Other common features are headaches, progressive cognitive decline, and acute or subacute encephalopathy, which is often characterized by an acute confusional state that may progress to drowsiness and coma. Cerebral angiography is often used for diagnosis. However, the specificity is low, and the results must be interpreted with consideration of the patient's medical history, as well as clinical and laboratory findings and the results of MRI and MR angiography. A CNS tissue biopsy showing vasculitis can provide a definitive diagnosis. Small vessel and medium to large vessel inflammatory involvement characterize two subsets of primary CNS vasculitis with different diagnostic methods, biopsy versus angiography, and distinct clinical characteristics and outcomes. The differential diagnosis includes reversible cerebral vasoconstriction syndrome, intracranial atherosclerosis, intravascular lymphoma, moyamoya disease and syndrome, secondary cerebral vasculitis, which can occur in connective tissue diseases, systemic vasculitis, and infections. Early recognition is important because treatment with glucocorticoids, with or without cytotoxic drugs, particularly cyclophosphamide, is effective in many patients and may prevent serious outcomes. A 47-year-old man with confusion and kidney failure. A case record of the Massachusetts General Hospital by Sachin Shah and co-authors. A 47-year-old man was admitted because of confusion and acute kidney failure. 6 days earlier, fatigue and myalgias developed. During the subsequent 2 days, he continued to report to his job at a restaurant. 4 days before this admission, the patient's co-workers noticed that he was mildly confused. On the day of this admission, the confusion markedly increased, and new word-finding difficulties and garbled speech developed. The patient was brought to the emergency department. On evaluation, the patient was not able to participate fully in the interview or a review of systems because of confusion, but he described feeling hot and short of breath. The patient lived in an urban area in a former factory that had been converted to apartments. Laboratory results revealed a white cell count of 13,270 per microliter and a creatine kinase level of 28,581 units per liter. This patient had an acute illness that was characterized by non-traumatic, non-exertional rhabdomyolysis, oliguric kidney failure, lung consolidation with systemic inflammation, encephalopathy, and liver injury. Multiple viral, fungal, and bacterial infections can cause rhabdomyolysis. 2 bacterial pathogens warranted special consideration: Streptococcus and Legionella. Infection with either of these bacteria can cause rhabdomyolysis and lung consolidation and could result in a disease similar to that observed in this patient in terms of severity and acute onset. However, the findings on presentation and results of laboratory tests alone cannot reliably distinguish one from the other. A Legionella urinary antigen test was positive and confirmed the diagnosis of Legionella infection. In this case, the source was probably the ventilation system of the converted factory where the patient was living. House staff unionization, an historical tool revisited. A Medicine and Society article by Ahmed Ahmed from Brigham and Women's Hospital and Scott Podolsky from Harvard Medical School, Boston. In recent years, physicians in training, house staff, throughout the United States have begun unionizing at an accelerating rate, with trainees at even the country's most prestigious programs joining this movement. House staff at Mass General Brigham, the University of Pennsylvania, Stanford University, Northwestern University, the University of Chicago, all have unionized within the past 2 years. Such efforts have been polarizing, and more senior physicians have responded with both praise, such as lauding of house staff for organizing to create change, and criticism, such as worries that unions will make residency less educational and more vocational. But house staff organizing for reform is not new. The past 9 decades have borne witness to its effects on trainees and the medical profession more broadly. The problems inspiring house staff to organize have endured for those 90 years. Concerns about working conditions, patient care, and compensation remain top of mind. Believing that it may be useful in this moment to step back and re-examine key moments in that history, these authors focus in this article on the origins of house staff organizing in the 1930s, the impact of trainee strikes in the 1970s, and the subsequent legal turmoil over unionization. This history highlights the enduring rationales for unionization and the tensions that both lead to and emerge from such efforts. The examination reveals a complex history of unionizing in physician training programs, which has resulted in gains, but also moral conflict. With many new unions forming, it is important to consider how this wave of organizing can be different from past ones. Ethical challenges associated with pragmatic and cluster RCTs, a perspective on the fundamentals of medical ethics by Charles Weyer from Western University, London, and Monica Talliard from Ottawa Hospital Research Institute, Ottawa. You are part of a discussion at your community hospital about whether your site will participate in a pragmatic, individually randomized controlled trial, RCT, comparing 2 antibiotics currently used to treat infections in hospitalized patients. Use of the antibiotics varies widely among physicians, and the drugs are associated with different, potentially serious side effects. Since these 2 antibiotics haven't been compared in an RCT, it is unclear which one is more effective. The investigators don't plan to recruit patients and will use routinely collected data for outcome assessment. They believe that a waiver of consent would be beneficial because it would permit inclusion of hospitals in underserved communities with minimal research infrastructure. During the discussion, the ethics of waiving consent are questioned. A colleague asks, would the use of a cluster randomized design strengthen the case for a waiver of consent? Conducting a cluster RCT would involve randomly assigning hospitals rather than patients to treatment groups, and all eligible patients at a hospital would receive the same antibiotic. Pragmatic and cluster RCTs offer opportunities for advancing research but present ethical challenges. Pragmatic RCTs, performed with the goal of informing clinical decision-making, tend to include diverse groups of patients and may be conducted in settings in which standard approaches to obtaining informed consent are impractical. Cluster RCTs, in which groups are allocated to study interventions, challenge approaches to research ethics rooted solely in the protection of individual participants. Addressing these issues requires multidisciplinary expertise and meaningful collaboration among stakeholders from various disciplines. Ethical guidance on specific study designs is needed. Facing these challenges presents an opportunity to revisit and deepen understanding of core concepts in research ethics. The sense and sensibility of sensitivity analyses. A perspective by Debbie Cheng from Boston University School of Public Health and Joseph Hogan from Brown University School of Public Health, Providence, Rhode Island. Clinicians and public health officials routinely make evidence-based decisions that affect patient and population-level health. The need for a principled approach to assessing and interpreting the robustness of findings from scientific investigations is more critical than ever. Randomized clinical trials frequently incorporate sensitivity analyses, for which relevant guidelines are available from the Food and Drug Administration and others. Yet misconceptions persist regarding their purpose and the proper reporting of their findings. Greater clarity is needed, since sensitivity analyses have the potential to influence a trial's conclusions, shape its narrative, and affect both policy and practice. Sensitivity analyses assess the robustness of a trial's findings by evaluating the degree to which analytic decisions and assumptions affect trial results. They should be pre-planned and included in statistical analysis plans. They should be designed to evaluate whether analytic choices or challenges, such as missing data, influence inferences regarding treatment effect. Post hoc sensitivity analyses may sometimes be needed. However, their use should be well justified, for instance, by violations of assumptions underlying the primary model, and minimized because they introduce multiple potential sources of bias, such as data dredging, selective reporting, and inflation of the type 1 error rate, and thus have less credibility than pre-planned analyses. In this article, the authors make several recommendations for reporting sensitivity analysis findings. No one in charge. A perspective by Janet Gilsdorf from the University of Michigan Medical School, Ann Arbor. Dr. Gilsdorf didn't know him. He said hello when he took the aisle seat beside her on their 4-hour flight to the West Coast, and then they didn't speak until about 45 minutes before they landed. Dr. Gilsdorf learned that he was a retired military officer, and he learned that she was a retired pediatrician. In a quiet voice, he told Dr. Gilsdorf that his wife had died about a year earlier and that his kids were pressuring him to move closer to one of them. He said she was diagnosed with cancer and was dead 6 weeks later. That's pretty tough, Dr. Gilsdorf said. He nodded. The hardest thing about her long hospitalization was that no one was in charge. No one in charge? Dr. Gilsdorf hesitated, and then awkwardly she explained that every inpatient has a physician of record, the doctor in charge. But what did he mean by no one in charge? He was probably referring to the team, the physicians, nurse practitioners, physician assistants, nurses, residents, and students who provide clinical care at teaching hospitals. His comments made it clear that he saw this group as disorganized and leaderless. Well, he said in measured tones, When she was first admitted, a guy introduced himself as her oncologist, but I never saw him again." He paused a moment and then added, "Never." During his military career, he and everyone around him had always known who was in charge. They could tell immediately from the rank titles and the ribbons on the uniforms. Medicine has also been characterized by and soundly criticized for its hierarchy. The concern has been that care providers at the top of the hierarchy may not recognize or sufficiently value the expertise of those thought to be at a lower tier. But programs designed to cure the ills of the medical hierarchy focus solely on benefits to team members or to the health system, rather than to patients and families. In the effort to flatten the hierarchical mountain, something very valuable has been lost. How did Dr. Gilsdorf's seatmate come to feel the way he did about his wife's care? Had he not been made aware of behind-the-scenes activities of his wife's physicians as they consulted radiologists, surgeons, and other medical specialists, combed the oncology literature for reports of new treatment options, and debated next steps? Clearly, he hadn't. The man knew systems, and the medical system, to which Dr. Gilsdorf had devoted her own professional life with great pride, had failed him terribly. In our images in clinical medicine, a 44-year-old man presented with a 5-year history of heat intolerance and burning pain in his hands and feet. He had periumbilical angiokeratomas and non-nephrotic proteinuria. A kidney biopsy was performed. Electron microscopy of a sample of kidney tissue showed lamellated deposits typical of globotriaosylceramide in podocytes, a finding known as zebra bodies, which are characteristic of Fabry's disease. In another image, a 59-year-old man was brought to the emergency department after a motor vehicle collision. The steering wheel of the patient's car had struck his chest after the airbag had not deployed. Physical examination was notable for ecchymoses on the chest and abdomen. There was also inward collapse of the anterior and right chest wall during inspiration and outward expansion during expiration, shown in a video at NEJM.org. A diagnosis of flail chest, paradoxical movement of a segment of chest wall due to multiple rib fractures in multiple places, was made. This concludes our summary. Let us know what you think about our podcast. Any comments or suggestions may be sent to audio@nejm.org. Thank you for listening.